Thanks for helping.
Kia ora koutou katoa, e te mana whenua o tēnei rohe nai tua huriri kei te mihi. E te whānau, tēnā koutou, tēnā tātou katoa. Ko Matthew Turnbull tōku ingoa, nō reira, nō mai tōti mai ki tēnei hui. Welcome folks, great to see you all. It's a pleasure to welcome you to this special University of Canterbury public lecture, which also serves as a celebration of the 20th anniversary of the GeoHealth Lab at the University of Canterbury. So my name's Matthew Turnbull, and I have a very brief, which is to do a little bit of housekeeping and to get the ball rolling. So just from a housekeeping point of view, certain things need to be said. So if you're looking for the toilets, we've got toilets on either side of the lecture theatre. And in the event of a fire alarm, please, from our UC staff, they'll be very, very helpful. You all know in the unlikely event of a tremor or an earthquake, please stay in place, drop, cover and hold. Should we need to evacuate, then the collection point, or the point at which we congregate, is your left out the building, my right, and out into the open area outside the lecture theatre. So it's really great to welcome you here for this celebration. We're going to have some speakers and some questions, which is going to be fantastic. As it says up there, I'm currently the Executive Dean of Science, and so I have a rather distant association with the GeoHealth Lab, but I do have a personal connection, and that is my son graduated about 5-6 years ago. I should have got the exact date, but with a master's in GeoHealth, and so I feel like at least I have a personal connection. So I'm a card-carrying member of the GeoHealth Lab whānau. So that's my personal connection. We are really fortunate to have a fantastic lineup tonight, and I'm going to start by welcoming Professor Malcolm Campbell, who's the current director of the GeoHealth Lab, to start the ball rolling and give you a sense of what's been going on. Kia ora.
Thank you, Matthew. Well, welcome. Tēnā koutou katoa, ko Slieve Gallion te monga, ko Lagan te awa, ko Tauhere te kanga, ko Malcolm tōku ingoa, nō reira, tēnā koutou katoa. The thing I really like about doing mihi, of course, is it's inherently geographical, and so you start off talking about places. So this is the mountain on my family farm in Northern Ireland called Slieve Gallion. This is the River Lagan where the Titanic was built. It was fine whenever it left Belfast. And this is Christchurch, where I now live. So I thought what I'd do to start with is explain just as briefly as I can what GeoHealth is. And so the way I thought about doing that was to show you pictures of babies, because that's inherently endearing, but also to start with a story of life. So if you think about it, whenever you're born, which most of us seem to be, you're born into a neighbourhood or a community or a family. And right from the start, all sorts of decisions are made that start to impact on health. So it might be decisions to get vaccinated or not. It might be how many people live in your household. All sorts of things start to impact on your health, even at this age. And then you either age gracefully or disgracefully, and you become an older adult. And again, you have a kind of a culmination of all those kinds of choices that ultimately will have impacted you over your entire life. And what the GeoHealth Lab does, essentially, is to look for opportunities to intervene across the entire of your life in a very specific way, using the lens of neighbourhood. So that's kind of what we're all about. And we do that using maps and statistics and data. So We've been doing that for about 20 years now, compiling all sorts of data and evidence and really working quite closely with people in the health community. So you might want a slightly more formal definition. So this is kind of what GeoHealth is from a kind of academic perspective. So it's a blend of sort of three broad domains of expertise, which is sort of geography, GIS, so geographic information systems. So we're interested in place, we're interested in drawing maps, and we're also interested in access or accessibility. So how close are things, how many things are within a certain radius or distance. Then we're also interested in the environment, and Simon will say something about this in just a second as well. But we're interested in green space and blue space, so parks, rivers, proximity to the ocean, or kind of features of the environment like air quality or ultraviolet exposure, or even social connections. And then we also draw on aspects of public health, so understanding disease and illness, but primarily trying to understand where we can prevent certain things from happening or intervene to change the trajectories of individuals. So I hope that kind of makes sense as sort of a segue into the rest of the talk. So as an example of some of the kind of questions we're interested in, we might want to know whether being close to green space, so parks and trees, improves your health and well-being. Or you might want to know how far the nearest hospital is. That matters more or less at certain times in your life. But also, and most importantly, we want to know how that access varies by particular groups in the population. So these are the kind of questions that you'll see as we go through this evening's talk, and hopefully all of you find something interesting in the talk over a 20-year horizon. So what I want you to think about as we go through the next series of speakers is, can a place change your health? How might this happen? Why might this happen? And when might this happen? So what we have to start is a video from the founding director, Professor Jamie Pearce, who joined us from the wonderfully summery Edinburgh and has given us a video. So hopefully this kind of makes sense in terms of we couldn't fly Jamie over, obviously, at short notice. So he's provided us with a short video. So I'll let that play, and then Simon will come and explain the more current kind of aspects of our research, and then I'll finish up with some future directions, and you'll have a chance to ask us questions as well. So I'm taking a number of risks tonight, one of which is playing a video in a PowerPoint, and the other one of which is my 5-month-old son is in the audience. So it's a question of which of those risks is going to erupt first. Okay.
Kia kokoto. Good morning from a very cold and frosty Scotland. My name is Jamie Pearce, and I am Professor of Health Geography at the University of Edinburgh. But in a former life, I was a member of staff at the University of Canterbury and was the founding director of the GeoHealth Laboratory for its first 5 years. I'm really pleased to be able to join you, albeit remotely, to celebrate what is unbelievably 20 years of the GeoHealth Laboratory, but of course really sad not to be there to join the festivities and to catch up with great friends and colleagues. So in this little snippet, I want to spend a few minutes saying something about the GeoHealth Laboratory, particularly an historical perspective, how and why it came about, some of the initial ambitions of the GeoHealth Laboratory, which I think, as you'll see, probably endure right through to 2024. I want to start by talking about some of the context for how the GeoHealth Laboratory came into existence. And I think there are three key elements to understanding the emergence of the lab. I think broadly in policy making in New Zealand, but also internationally, there's a great deal of interest emerging about place-based policy making, So how we can design and change places to support policy making, support behavioural change, support impacts and outcomes. And that was certainly true in the public health sphere as well. So there's lots of interest in how we can develop place-based policy making to address some of the major public health challenges in New Zealand back in 2004. At the same time, we saw the emergence of geospatial technologies into the mainstream. It had emerged from being a relatively minor academic pursuit into something that was widely used across the public and private sectors. So the emergence of GIS and then later sensors, sense data, remotely sensed data, and then technologies such as GPS, which are of course much more mainstream now, but were really coming to the fore back in 2004. And then not unrelated, there was an increased availability of data, geocoded data of individuals. So we knew where individuals lived and worked. We were able to say something about the context environment in which they lived. Alongside that, much more availability of geographical data, people recognizing the importance of geographical data, collecting it and using it. And of course, the linkage between the two. So we've got much more sophisticated ways of bringing those data together in ways that have proven powerful from a research perspective and certainly from a public policy perspective as well. So there's all this background of things coming together. At the same time, there were some very forward-thinking people in New Zealand government, colleagues in the Ministry of Health in particular, who recognised that whilst there was this emerging data and this emerging field of geospatial technologies, we lacked the capacity in New Zealand. There were very few people trained in this area, so we really needed to try and develop further capacity to help support the growth and development of this area. And at the same time, it was important to try and develop the evidence base and improve outcomes. The 2000 New Zealand Health Strategy was certainly a driving document in terms of the establishment of the lab. And there was a recognition that we needed greater intelligence to help us develop policies that would support some of the ambitions of the strategies. And critical to that was some of the geospatial health research, as we'll see in a moment. So recognition is there was lots of opportunities here for the reasons I've already discussed to make greater use of geospatial approaches to support policy development, not least the health strategy at the time. And then finally, thirdly, there were, I think, some local particularities here at University of Canterbury, which were absolutely essential for founding the lab. And perhaps firstly and most fundamentally, we had a long track record in health geography research, people interested in these sorts of themes. So the work of Ross Barnett going back over many years, and then Simon Kingham arriving, and then finally me in 2003, and other colleagues such as Clive Sable with similar interests. We had a strong critical mass of academic health geography research in this area, which gave us a particular advantage. Also, equally important, really critically important to this, was our technical capability, particularly our technical staff in what was then the Department of Geography. We had technical staff with superb skills in GIS, geospatial more generally, and they were critical, I think, for presenting a strong case to the Ministry of Health for why we were the best place to host the GeoHealth Laboratory. And then finally, it seems like the sector, this has become very kind of mainstream and very normalized now for us as academics to think about the implications of our research. But the PBRF, I think the first one came in 2003, if I remember correctly. So, of course, we were very fresh from our first PBRF and being really encouraged / forced to think about academic impact. So this was, I think at the time, a really novel way to address those connections between academic research and policy making, and to really work side by side to develop research that was informing policy and making sure that our research was fit for purpose, was really clearly steered towards some of those important policy related questions. So those, I think, are the three factors that sort of underlay, were the sort of precursors for the establishment of the GeoHealth Lab. So this slide gives a flavour of the lab as it became established back in 2004. You can see that we developed our relationship with the Ministry of Health, sort of that 2003-2004 period, and the key people involved in those early days were myself, alongside Simon Kingham, I think he's here today, and then Eric Pawson and Wendy Lawson, who were the heads of department during this period. And then from the Ministry of Health, Paul White and Barry Borman. So we worked closely together to think about what the lab was trying to achieve, how it was going to operate, and what some of the plans for the future were. And that the diagram there gives a bit of a flavour of some of the things that were key elements of the lab. So we had this, importantly, had this co-director model. So myself from UC and Paul White from the Ministry of Health, we worked together very closely throughout the time that I was involved. We established, what the priorities were, how he's going to operate, and broadly some of the plans. Clearly, what was critical in terms of bringing all these themes together was this integration of geospatial approaches into public health policy making. Those were some of the key principles. But we were also, it was also important for us to think about capacity building. We were interested, of course, in delivering research, but also important was to fund postgraduate researchers and research assistants to develop expertise in geospatial skills and techniques, but also applying them in the public health realm as well. And co-production was very much critical and underpinning everything we did. The 13 priorities identified in the 2000 New Zealand and health strategy were very much guided what we were doing. We'll see a bit of that in a moment. We thought about what are the key contributions we can make to those 13 priorities, guiding us, guiding our work, and broadly what the funding from the from the Ministry of Health did was to provide funding for postgraduate researchers, research assistants, consumable equipment, and then at Canterbury we would contribute some of the overhead such as desk space and academic time. So that was the broad collaborative model that we developed. So with those principles in mind, it all came together and we had our launch. Here are some photos from our launch. Some of you who have been at UC for a while may recognise some familiar faces from the past here. You can see our then Vice Chancellor, Roy Sharp, helping us get us underway. Then the Director General of Public Health, Don Mattison, is there. Eric Pawson, Wendy Lawson, those four in the top left photo there. You can see some other colleagues who are also heavily involved. Paul White and I, who were co-directors, all of us looking remarkably young at the time. I've certainly got a lot more hair then than I have now. There's a few photos from that day. We also had a visit very soon afterwards from the then Prime Minister, Helen Clark, as you can see here, and there's Catherine Tish, who is possibly in the audience today, who's really important in some of our early research. Catherine worked as a master's student and showed some of her findings to a very impressed Helen Clark. So it was great for us, I think, at the time, just to have that kind of high-level buy-in from New Zealand government. And finally, to say something about some of the early research that we did in the lab that was contributing to 7 of the 13 priorities in the health strategy, and that, as I indicated before, we co-produced with colleagues in the Ministry of Health. And I guess there were 3 main themes in those early days. Firstly, health inequalities was and continues to be a major policy issue, a major concern in not just New Zealand society, but internationally. And we were looking at how health varied across New Zealand, both in terms of life expectancy and morbidity, and how that had changed over time. And clearly there's been a growing gap in terms of health inequalities over the previous 20 or 30 years. We see this both socially between different social ethnic groups, but also in terms of the geography, so more geographically uneven. So we did some work around that. Secondly, we worked towards what became the New Zealand prevention strategy in relation to suicide. We looked at some of the geography of that, contributed to the monitoring reports, and looked at some of the place-based risk factors in relation to suicide. And I think that's something the lab can be particularly proud of, the way that we contributed to that strategy and the beneficial outcomes that came out of that ultimately. And then thirdly, work, which I know is a theme that endures in the GeoHealth Lab, around neighbourhood community resources and health. And this was very much a new field at the time, thinking about how local resources in the places that we live, so retailers, parks, recreation centres, green spaces, transportation and so on, can be important in terms of supporting local health outcomes and indeed supporting what we might think of as healthy approaches to planning. So as I say, it's now a very large research area, but something we worked on in those sort of early days in the lab. So I hope that gives you a bit of a flavour for how the lab came about, its early emergence, some of the, I guess, early strategies and ideas that we had, and then finally a little flavour of some of the work. I'll now hand over to others to talk about some of the more recent work and plans for the future. Thank you very much for listening.
So, kia ora, my name is Simon Kingham. I'm a professor of geography here at the University of Canterbury, and I was for a number of years the director after Jamie moved on. One of the things I want to talk about is how the lab evolved after he left. So he explained the structure with the co-directors, with one director in Wellington. It changed so that the ministry's staff changed. So at the same time Jamie left, Paul White also left. And the ministry said, and Jamie had already planned this as part of him leaving, that they would have a new role in Wellington. So we employed a researcher in Wellington. We ultimately, subsequently employed a manager in the lab as the lab grew. So we generally had 3 research staff down here, the person in Wellington who was employed by us but based in the ministry. And the idea was that seamless connection between people delivering policy and us doing the research. We then had the postdocs, so we've always had a number of postdocs. And we've also had a number of, over the years, of student scholarships. And it's varied between having PhD and master scholarships. And then we also had scholarships for Master of Spatial Analysis and Public Health students. Now, this was a program delivered at the express wish of the ministry. And as Jamie's mentioned, and Malcolm will mention later, geospatial science is a skills shortage area in this country. We can't get enough people to do this role. So you probably already noticed that the 3 people speaking are not Kiwi born. And that is partly because we don't produce enough people with geospatial skills, so we tend to import people to do that role. And that's part of the reason the ministry asked us to develop this master's. The other thing that changed is, over the years, it became more overt that they wanted the policy, the research we did, to be directly linked to policy. So it kind of always was, but it was sort of done informally. So one of the things that started to happen increasingly over the years is every single project would have an MO, or Ministry of Health policy stakeholder on a steering group. So every project had a steering group, including the researchers, and it included somebody from one of the policy teams. So whatever research we were doing, somebody outside, without geospatial expertise, would come in and fill that, be that person, ensuring the research we did was policy relevant. Part of that, we would agree an analytical plan. So we would agree this is what we were going to do at quite an early stage. And the ministry could say, no, we don't want you to do that, or we might occasionally say, we don't think we can do that. So that was agreed. We reported formally quarterly on every project. So we would submit quarterly formal reports so that they could be seen around the ministry. And we also agreed the nature of the outputs we would produce. So we would produce the long reports, which was in essence an academic publication, but with lots of detail in. We produced a short plain English reports because we understood that not everyone understood the technology speak that we sometimes use. We would produce a very short summary for a minister, so that had to be in super plain English. And that's not being disrespectful, it just had to be something very short that a minister could read and understand the policy implications of. And then finally, but not always, we would try and produce academic papers. So some of the projects we're going to talk about later don't actually have an academic paper because they weren't suited for that. There was never any control over what we couldn't publish. It was very much a case of this just doesn't merit academic publication. So kind of that was the process we did. And over the years, in 2018, this work was done for us, actually just calculating the number of papers. So you can see from 2005 through to 2018, a significant number of academic publications. And one of the things we think that this does is it adds academic rigor to research done for a policy, a government department. So a lot of research is done, but this adds that international peer review process. So you can say it's peer-reviewed and high quality. So just to get a sense, and Jamie's touched on some of this, of some of the sort of research we've done over the years. One of the themes has been on the impact of where we live in the context of green space. So for example, we've done some research looking at green space and physical activity, but the second mechanism about green space, one is that green space provides places you can get exercise, but the second mechanism is that green space, just seeing it is good for our mental health. And so as an example, we did this project working with a student, Daniel Knutsford, one of our postdocs, and what we did is we calculated the amount of green space in a circle around where someone lives, and our second measure was the distance to the nearest green space. So we had two different measures, but you can see they're using geospatial science to calculate your exposure to green space. And that found that with decreased distance to usable green space, an increased proportion of green space within your neighborhood were associated with decreased anxiety and mood disorder treatment. So in other words, the more green space you live near or the more green space you're close to, the better your mental health. A follow-on from that is we started getting interested in blue space. So in other words, what about being near the sea? How good is that for health? Now, one of the challenges with that is, so we looked at this in Wellington, is you can be a long way from the sea and see it, and you can live really close to it and not see it. So we had to actually do a thing called viewshed analysis, where we actually calculated the amount you can see from a particular place. Now, that kind of sounds straightforward, but geospatially, it's actually really complicated. Because you're imagining, you're saying, how much blue space can I see? And you don't include the sky, you're talking about water. So we did that and we identified an association between increased views of blue space and decreased psychological distress. So in other words, the more you can see, the better your mental health. And all our studies controlled for socioeconomic status. So we know that the wealthier people often have a view of the sea, so we've controlled for that. And once you control for that, you still find that the more blue you can see, the better your mental well-being. So there's some examples. Another one we've done is we've done some work on proximity to alcohol outlets. So the first time we did this was some work in 2011, published in 2012. So we said, and we, not surprisingly, found that in low decile areas, there are more alcohol outlets, and having greater geographic access to alcohol outlets is associated with increased levels of serious violent offending. So the more alcohol outlets near to where you live, the greater the chance of serious crime. This is a piece of research where we regularly get contacted by people saying, somebody wants to put an alcohol outlet near where I live. What's the research tell us about that? And our research tells us that's probably not going to be good for a number of outcomes, including violent crime. We did this research, and people would contact me occasionally and say, can you send it? And then they were getting the message, the alcohol companies are arguing that research is now out of date. So we did it again. In 2020, because of this very reason, people were saying, that's old now, you need to do it again. So we did it, and guess what? Close proximity to alcohol outlets was associated with increased hazardous drinking, and close proximity to alcohol outlets was associated with increased crime. So we found the same thing, and I imagine we'll do this in about 7 or 8 years again, because they will be arguing that's out of date and it doesn't apply today. But it's research that is referred to by communities who are concerned about increasing numbers of alcohol outlets going in near where they live. Next piece of research is vapes. This is some research done in the lab by Lucas Marek and Matt Hobbs, two of our colleagues, but also including Mike Epton is a respiratory physician in town, Annabelle Ahudi-Driscoll is a Māori researcher here, so we're often bringing in teams of other people in some of these research projects. This shows vape store openings over time, and what you can see at the bottom is in the least deprived areas, yes, they've increased the number of vape stores, but not at the speed at which they have increased near low-income communities. So kids in low-income communities, and adults, but I guess we're particularly interested in kids, are exposed to more vape store being opened in low-income communities. And this was picked up by the media who interviewed Matt and reported that a third of Christchurch vape stores were within 400 metres of schools. So concerning research. But again, it's just part of this picture of looking at the impact of the environment on well-being using geographic approaches. And I guess the ultimate one was a piece of research, again, led by Matt Hobbs and Lucas, where they decided, or they designed a way of looking at what we call the goods and bads. So goods and bads and the impact they have on well-being, and this was developed across the whole country. And it's been used, this measure of exposure to good and bad environmental things has been used on a number of studies looking at physical and mental well-being. And again, just looking at an interesting example of the impact, the Real Estate Association of Australia actually interviewed Matt as part of their research, as part of upskilling people involved in the real estate industry, and came up with the headline, How Where You Live Could Be Making You Sick and What We Need to Do to Prevent Mass Illness. So again, you're getting uptake amongst people who are interested outside New Zealand, but also within this country, looking at the impact of the environment on our well-being. Just to change tack slightly, we've also done some research on health facilities and the location and how you plan health services. One study we looked at Healthline. So some of you will be familiar that you can phone up Healthline and say, this is how I'm feeling, and a qualified medically trained person will tell you what you should do. And they generally have three things. They say, go to hospital now, you're probably sick. Go to your doctor tomorrow morning if you're not feeling okay still, and go to your doctor in a week if it's still not improved. And the one in a week means you're probably not sick. And what it found is these are distances. So what you can see is once you live more than 40 minutes distance away, the percentage of people who called who actually go to the emergency department is under 15%. Within 30 minutes, it's upwards of 40%. And so what we found is that travel time to ED has a dramatic impact on whether you do what you are told, according to what you are told to do. Those living closest were more likely to attend even if they're told not to, and those living far away are highly unlikely to go whatever they're told to do. So the argument is here that what you're told to do, yes, does impact the chance of you going to hospital, but also how close to hospital you are also impacts the chances of you going to hospital. If you live close, you're going to go. If you live far away, you won't, even despite whatever you're told. So this is an example of the sort of research we do. We also had some projects looking after the earthquake, with an excellent student called Daniel Hogg. And again, on this piece of research, Michael Arder was the head of the emergency department in Christchurch Hospital. Tom Wilson is a hazards and disaster researcher. So again, we bring other people in on these research projects. The idea of this was that there was research saying at the time that the least affected areas the most affected areas did not have the most people being ill in terms of their mental well-being. And so we said, well, that might be because they're moving. So in other words, the people who are the most affected have actually moved out of those areas, and you actually need to factor in how people move. And so we did, and what we found is that people who relocated permanently were affected in the long term, and people who were relocated temporarily in the short term. So you need to target different groups of people according to the time after the natural disaster and where they live. And the point of this is, and Malcolm will talk more about this later, is it's actually not just good enough to look at where people are at the time something happens. You actually need to understand how they move around their communities during particular events and afterwards. This was done in a fairly simplistic way, but with good data. Malcolm's going to talk about some of the cleverer ways we can do that as well. Just to give an indication, these are some of the other projects. I went through some of the quarterly reports and the annual reports to get a flavor of some of the other projects we've been involved with. So access to audiologists, avoidable hospitalizations, obesity, green space and academic achievement, aging, immunization for children and adults, hospitalizations, trauma injuries, location of Māori GPs, more obesity, maternity outcomes, mobility and pandemics, oral health, population transience and healthcare, and a couple of projects on smoking. Just to give a flavor of the sort of things we've been doing in addition to some of the stuff we've got published. One thing that's happened over the years is the team has evolved. So this is our team photo in 2009. You can see Catherine, who was mentioned earlier, and there's somewhere in here. And on the right, bottom right, is Ed Griffin, the guy who came as the first person employed to be in Wellington. The team changed a bit. There's one consistent person whose hair is going increasingly light, as you'll see. I did look rather young. It's amazing. I know. The team kept changing. Now you've seen John McCarthy, who's here today, who became our postdoc here and then moved to become the connection in Wellington. There's Malcolm has now arrived as well. And there's the team again, and in the middle we've got Denise Sitano, who was the person in Wellington who was kind of responsible for the contract and worked with John. And then 2019, that was our latest team photo. We need to do team photos again, Malcolm, but we haven't done one since 2019. And there in the very bright tie is the former Deputy Vice Chancellor here. So the team has evolved. We think there's big added value. So one of the things that the lab has done is we've managed to attract a lot of really good international visitors to work with us. So it's the presence of the lab and the academics associated with it, so the likes of Malcolm and I, Jamie and Ross Barnett. We've attracted all these really good people who then do research with us at no cost to the New Zealand government or the university. So that's a cool outcome. And we've also produced some excellent graduates. So these are the graduates over the years who've come through the GeoHealth Lab and done masters or PhDs in some of the sorts of places they've gone on to. We are just this week celebrating Phoebe, our latest PhD student, who submitted this week, and I think Susie, either this week or very, very soon, is about to submit. So we're producing people who go on, and some work in the health sector, most stay in New Zealand and work, and many go into these geospatial areas where we have a skills shortage area. So we're adding capability and capacity to NZ Inc. So I'm now going to pass on to Malcolm, who's going to talk a little more about some of the next steps and the future things that might happen.
Cool, thank you. Hopefully that's kind of giving you a flavour of what we've done over 20 years. And so now I'm going to do something quite dangerous, which is speculate slightly about the future. Some speculation, some things that I think are going to happen. So the first big trend that hopefully you've picked up from even early in Jamie's video, and some of the things that Simon has talked about, is kind of the complete change in the sort of data that we have access to. So we still use the census and health surveys to tell us about the health of populations, but increasingly we have access to things like mobile phone data, social media data that's really detailed and really regular. And then with that, we have this integration of all sorts of new technology. So GIS itself, the mapping software, has improved fairly substantially. And then, of course, AI everything, right? So AI is the buzzword at the minute. My original pitch for the presentation photo was this. So I asked AI to generate the GeoHealth Lab. That's roughly what I came up with, which is not too bad. And so you can see that there's tremendous opportunities, but also challenges in terms of representation with things like AI, which make it problematic and useful in equal measures, perhaps. And then also the use of smartphones and mobile phones. The really cool stuff is the idea that we can now begin to think about tracking and understanding health in really fine detail over an entire life course. Right? So we can get much finer, more specific and targeted responses about specific diseases over an entire life course. And that might be something like respiratory disease, connecting that to air quality, but it can also be more subtle things like social connections, social networks, mood, well-being, and those kinds of things as well. The other big change that is coming our way is some of the really quite profound shifts in demography. So some of you may be aware of this, some of you perhaps less so, but there are some quite interesting, stark perhaps, demographic forecasts around how rapidly we're going to age as a population. And also alongside that, how the kind of ethnic diversity, if you like, of New Zealand will move around as well. And then I'll finish just by saying something about what I think has actually stayed the same over 20 years in terms of the themes. So first of all, I'll show you what it looks like in terms of pictures, because I like showing maps apart from anything else. So this is the kind of data that a lot of what Jamie and Simon talked about is based on. So once every 5 years, we have a census. And so we kind of know where people are once every 5 years, but not really much in between. And that was what a lot of the research used to be based on. Then actually, during the last national government, Bill English introduced the social investment approach. And as part of that, there was this data set called the IDI, which is kind of all your government and administrative records. And we can use that to understand more rapidly what's actually going on with the population. So this is all the places I lived over 7 years in Christchurch, post-earthquake. So I moved about once every year for 7 years. But that makes a big difference to risk of disease and illness if we're attaching that to a place, right? And then here's what my data actually looks like. This was before I had kids, over an entire year. And suddenly we're up to sort of 500,000 data points. And you can see how I move around New Zealand over the course of a year. These long lines aren't me kind of swimming to Australia. It's flights and that sort of stuff internally. So again, you get much more specific and fine-grained individual level data, which we can then connect to other things in the environment and tell us things about how the environment might or might not be impacting on our health. So what I thought would be interesting as well is to show you what that looks like sort of dynamically. So on the right-hand side of the slide is some of the data that we used during COVID, which I tried not to mention during the whole presentation, but I've snuck it in. But this shows some of that mobile phone data that we have access to. And this is kind of, if you like, the heartbeat of Christchurch. So we know what's going on hour by hour around our city, and the darker colours in each of these maps represent more people in each areas. So if you know Christchurch, it's unsurprising that a lot of people end up kind of along the Blenheim Road corridor and in the CBD as the workday kind of starts and ends. And then if you look at this map here, this is showing the year-by-year changes from 2006 to 2022. And again, for those of you who have been around Christchurch, you'll notice the changes pre- and post-earthquake and the kind of growth around Hallswell, Rolleston, Wigram as an example. So this is a fundamental change in kind of how we can link data to all sorts of environmental exposures, and again, over increasing lengths of time to really understand what generates disease or illness, but also what generates social connections or good mental well-being as well. Here's some of the demographic shifts that I think are going to profoundly change the kind of research we end up doing, but also will change how much healthcare is demanded by us as a population. So this rather apocalyptic chart, if you understand what it's saying, is basically saying that people like me who are paying taxes are going to grow very, very slowly, but the retirement kind of population, if it's still 65, is growing quite rapidly into the future. And what this means, of course, is that we're going to have issues around who ultimately ends up paying for healthcare. We all love paying tax, of course. And so this really changes that kind of dynamic of older New Zealanders and their demand for healthcare. So we know one thing is certain, that as you age, you're more likely to need healthcare. But what's really quite interesting is that this isn't happening for all ethnic groups in New Zealand in the same way. So if you look in bold in the brackets is the median ages for each of those ethnic groups. And hopefully you can see that some are younger, quite significantly so, and some are older. So if you compare European to Maori and Pacific peoples, for example, you'll see European ethnicities are in the 40s, Maori and Pacifica in the 20s. What this looks like, if you're interested, if you remember geography at all from high school and population pyramids, is that essentially you have more and more older people in the European ethnic categories and more younger people if you look at Maori and Pacific peoples. Okay, so, and again, that's just the whole of New Zealand. This varies place to place around New Zealand in quite important ways. So where older people live is going to generate demand for healthcare, and that generates all sorts of work in planning that going forwards. Then what I want to do now is just sort of wrap up a little bit with some of the enduring themes that I think have kind of persisted over time. So first of all, there's this idea that somewhat at a basic level, what we want to do is monitor health inequalities. So if we understand health inequality as sort of differences that are perhaps unfair between groups of people, understanding where these exist and how we might be able to alter them is actually quite important for us as a nation. Then I'll talk a little bit about an example of a place-based approach using some of the more recent smoking data. I'll also say a little bit about how this is still quite fundamental to all of the research we've done. So the idea that we still need to understand what access looks like to particular things, whether it's hospitals, doctors, or indeed things like green space, parks, trees increasingly. And then the really interesting thing when you go back over time is actually the words change subtly, but broadly speaking, the domains and the kind of main things that are the focus of the healthcare system are pretty similar over a 20-year time frame, right? So the most recent government policy statement on health still picks out things like alcohol, smoking, poor nutrition, kind of obesity, physical inactivity, and a range of adverse social and environmental factors. So we still want to understand how those things are evolving and changing over time. So for example, younger people are much less likely to consume alcohol than when I was a student and probably prior generations. And that's quite a fundamental shift in terms of alcohol hazards. The most probably relevant thing to a university is really this idea that we're still catching up or producing graduates in terms of skills shortages. And there's an opportunity to engage with that right in the very last slide after Q&A. But basically, we're still playing catch up in terms of some of the skills that we need. So here's what health inequalities look like. So in New Zealand, it may or may not surprise you to learn that if you look at your local authority and you connect that to life expectancy, there's about 8 years between the places with the lowest life expectancy, so somewhere like Wairoa, and places with the highest life expectancy, so Queenstown. And I still think that there's a case to be made that understanding why this happens, so all the kind of work that the GeoHealth Lab generates, is really attempting to understand these kinds of patterns. So I think that's quite problematic in a nation of this size, that there's those kind of differences. And you might think, oh, well, we're down in the South Island. It's not that bad, really. So what I did was I attached life expectancy to the Orbiter bus route, right? And so each individual bus stop, you can look at the life expectancy, this time for men. And so for those of you who know the geography of Christchurch, if you look along the foot of the Kashmir Hills, you're up in the kind of mid-80s, whereas other parts of Christchurch, you're down in the mid-70s. Okay, so again, you're getting that kind of range of life expectancy, even within a city the size of Christchurch. So it's really these kinds of things that we're most interested in doing research on and contributing to the policy response to. Other things that I thought are particularly timely and relevant. So just today, actually, the Smoke-Free Action Plan was released. So this is some data from the most recent census, which I assume you all filled out, if you remember that, filling in the forms or doing it online. And this is the data that comes from those forms. So we still have a target to reach 5% or less of the population smoking by 2025, which is in about a month's time. And so in 2023, here's how we were doing. So these kind of blue colors are really only the areas that are meeting that target in 2023. So the yellow and kind of green shades are still some way off. So what the lab essentially is doing is taking data like that and turning it into some sort of intelligence. So about a third of places in New Zealand are meeting that target, if you look at a binary map. And really what we want to know is about the places that aren't meeting the target. Now, as a geographer, I should point out that this is really to do with land area, even though it's 2/3 of the country. But you can still see that there's quite some way to go. And again, what the lab is really interested in is targeting resources to the places that actually need the particular focus. So ignore the areas in grey because they're kind of already at that level, but put resource into the areas in red, so quit smoking services or whatever it happens to be. So this is kind of an example of really what we're fundamentally about. So, really the final thing I want to say is around these policy priorities. So hopefully you've got a sense over the video that started, what Simon has said, and then some of the examples I've shown you, that we still do this research on issues that are highly policy relevant. Even this afternoon, we're responding to that kind of policy around smoke-free. And actually, we're really excited about doing research that's policy relevant because it can improve health for whole populations. And there's still this need to understand where in healthcare. So I've showed you lots of maps, so has Simon, around the kind of ways we can target these interventions. And how that might play out is that we need to know where the people are, so targeting the right people at the right places, and increasingly at the right time. So a lot of the things that we're kind of pushing into now with things like mobile phone data or the kind of big data that we have access to is understanding when things are open or closed, understanding where people are in particular places or in particular environments, again, to generate ultimately improvements to health and well-being. And these three pictures are taken from, again, that government policy statement on health, just signaling that these are the kind of things, again, that we will continue to do research on. So that's probably enough from me. Hopefully you've understood my accent and learned something about GeoHealth. All that really remains for me to do is really thank everyone who has contributed to quite an impressive body of work. The main challenge in curating this talk was to try and figure out how to integrate 20 years of stuff across 3 directors. We started trying to come up with a list of names, and we quite quickly ran into a problem, which was we couldn't fit them all in one slide. And we were also quite worried about leaving someone out, which became our major reason for not trying to compile an entire list. So just to say, I feel really privileged and proud to kind of lead the lab at this point in time. And there's several of you in the audience who have contributed to the work, so thank you very much. It always feels a bit naughty, somewhat taking credit for others' hard work, but really others have built a large platform of work which we continue to drive forward. So thanks to all of you for your contributions. And thanks to the audience as well for coming, because it's always nerve-wracking when you don't know how many people are going to turn up. So I'm going to hand over now to Phoebe just for some Q&A. Let her take over.
So thank you very much.
There's a wee click.
Oh, okay, working now. I'd firstly just like to express gratitude to Simon and Malcolm for providing us with such an insightful lecture this evening, especially to celebrate the 20th anniversary of the GeoHealth Lab as well. I feel very grateful to be a part of the GeoHealth Lab over the last few years and to work with such fantastic researchers. I would also just like to sort of express the GeoHealth sort of aspect as well, in terms of, I think it's been made very evident through the lecture this evening that the integration of geography and health is very important, and are two fields that often don't necessarily get put together, but I think it's been made very clear through the maps and the research and everything provided tonight that we do need to think about how the environment affects our health and the integration between those two fields. I'd like to start the questions session tonight by asking my own question. We've talked a lot about policy throughout this lecture this evening, and I know that John is in our audience this evening, who has spent time in the GeoHealth Lab himself. I'd like to ask if you could give us a little bit more insight about how the ministry and policy sort of integrated with the GeoHealth Lab.
At the front. Get up the front, yeah.
Thank you. So kia ora koutou. By way of introduction, I'm John McCarthy. I came over to the GeoHealth Lab in, I think, 2013 And within a year, I found myself at the Ministry of Health up in Wellington, still working for the GeoHealth Lab, but I was kind of the point person up there, as described by Simon earlier. I mean, I just had an absolutely fantastic experience up there, and I think the benefit of the GeoHealth Lab operating model, as best described for me, was a win-win situation for all. I think academia, and I'm really grateful that you put a slide up with all past projects on there, because I was sitting there panicking, thinking, I can't remember. There's not a great deal I can remember that we did. But I mean, alongside those projects, there was the kind of more week-to-week, month-to-month kind of churn of spatial projects that I think really added value as well, that weren't on that slide, because I think, engaging with strategy and policy in a government environment is unbelievably challenging for a lot of different reasons. I think primarily timeliness, that these cycles don't have the luxury of time. There's also things like staff churn. There's kind of priorities change. There's all sorts of challenges. So there's a lot of fortune involved as well, that you kind of have to be in the right place at the right time. You can mitigate a lot of that by building really good relationships. And as Simon said, you kind of build these governance groups that can kind of make the projects a wee bit more robust to things like churn and, a government coming or going. And other projects that kind of stood out for me that weren't on that slide, Simon, there was one around gambling harm caused by pokie machines. There was a project looking at kind of risk factors and harms that I think, from memory, had some kind of impact upon licenses being granted. There was another project around maternal health and midwifery kind of provision on the South Island that I think resulted in policy change. There was another one that I recall around sexual health as well, and access to kind of pharmaceutical services in rural areas. So there were heaps. There was a lot. It was a real constant churn of good work. And I feel so in my current role now, I work at ESR in health intel and surveillance. The challenges are exactly the same, and not just the challenges of kind of, I'm a step removed from government now, but the challenges are still there in terms of translation of science, timeliness, and I think a lot of these spatial questions we've been asking for some time. It doesn't go away. Geography is really at the kind of core of a lot of those decisions. So does that answer your question?
Yes, that's fantastic. Thank you very much, John. I will open the floor to anyone in the audience who has any questions. We've got one up here.
I have two questions. Hello? Yeah, please. I'm interested about the 400 meters. I read that somewhere as well about some countries ban the fast food within 400 meters from school as well. And so what is the policy about the a cohort of ethnicity or cohort of age group, instead of allowing them or indulging them to or develop a bad habit, eating habit, and then use a medical subsidy to remedy, solve the health issues. Instead, what's the policy to prevent that from happening in the first place, like prevent develop a bad habit? Another one is, as you said, the data the trending is that we have more and more individualized data, and so do you think that in the future the tendency would be, the policy would be more on the individual level instead of ethnicity level? And also you mentioned that our ethnicity has become more and more mixed in interracial marriage. So in the future, will it be more on individual level?
There's quite a lot to unpack there, so I'll have a go at perhaps one of them, so I don't end up giving another lecture. So you asked about the kind of proximity to fast food outlets and kind of a 400-meter buffer or 400-meter distance. What the lab essentially would do is we would look for all the fast food outlets in, say, New Zealand, and give policymakers some idea of how many people live within 400 metres. And if that's the kind of policy that a government wants to roll out, then they have at least some evidence to understand how that might impact particular populations, ethnicities, subgroups within the population. It doesn't necessarily have to be 400 metres around a fast food outlet, but you might be able to think of some places around Christchurch where there are serious concentrations of fast food outlets. You might call them the Munchin Junction, where there's all sorts of KFC, McDonald's, Burger King, or some other large multinational chain. And so that concentration is quite problematic, and it's quite hard to unpick once it already exists. So hopefully that answers your question, but happy to chat to you afterwards at length if you want. Yeah.
Great, thank you. Next question, we have one in here.
What about policy input into other ministries? And I think of MFAT and, say, health development in the Pacific. Are you able to do that? Do you do that?
We historically have worked, we were funded directly by the ministry. So we responded to ministry priorities. So we didn't really work with MFAT in that respect. We have done a project on the Pacific Islands, but that was, so some of the stuff we've talked about is mainly about what we did for the ministry. Some of the student work and other bits of work. So for instance, the work on earthquakes was not funded by it was actually funded by the Australian government, ironically, through a nature of a funding mechanism. So it partly comes down to who we're funded by. But historically, until 2022, we were funded directly by the ministry for the last 2 years. We've been self-funding, and we get research grants, and they dictate what we do. But most of the stuff we've talked about, directly funded by the ministry, so meeting ministry priorities, Ministry of Health.
I've got one in here, and then we'll take one over there.
Hi, can I just clarify definition of green space, blue space? Can you offset this by having an individual green or blue backyard with a pool or a nice lawn?
Yeah. So some of the research we did on green space, it kind of evolved and we used different data sets. So the stuff I showed you there was using public green space. We've also done some other work which uses remote sensed data to look at all green space. And you can do that. The problem is you start getting into some technical issues about things that might look like they're green space and they're actually tarmac, and then it gets complicated. The blue space one, the research we looked at is more about the seeing blue space, so seeing the sea. And there's other research that looks at people's relationship with the sea, and you call it therapeutic landscape research. So I think the visual stuff is about the sea and the surrounds rather than a swimming pool. The green space stuff, yes, it can be both, and that's why people are starting to use different ways of measuring it. So it's all about measurement and geospatial science.
Yeah, I'm interested in how you visualise and present data. And one of the issues, I think, is that health data is usually about people, and maps are traditionally based on area, and you alluded this to at one point. But can you just talk about some of the solutions or approaches you can use to transform the data so you can, like a little bit you did with that map, the pulsing heart of Christchurch, how you can transform the data to better represent it. Yeah. Because I think the smoking data was poorly represented from that point of view, because the urban areas took up very little of the space on the map but had most of the people in it. And the other aspect to that is, how do you go about educating students within your group and beyond, and staff beyond your group, on this question of good presentation, especially in using maps in more flexible ways to be better representations?
If I make one comment and you go on to the flashy stuff. Most of the publications we produce don't have any maps in. In fact, they look quite boring and they have tables and statistics and data. And so we actually kind of have to find the nice maps because they do look nicer, right? But most of it is data. We can't present point data ever because of confidentiality and ethics. And so you end up attaching information about places to individuals and then doing epidemiological statistics. So you're right, most of the stuff actually doesn't. In terms of the visualization, I'm going to pass to Malcolm. He's far better at this than I am.
I think it's actually a really brilliant question because the way that we do that is use things like cartograms. So we adjust the area by a specific variable to kind of, in the smoking map as an example, make it more of a balloon or shrink, depending on how many people live there. So if you've seen any coverage of the US election and you look at the map of the US that's red and blue, and then you compare that to something called a cartogram, the map looks remarkably different once you kind of account for the rural areas. And so that's what you can do. The problem with cartograms is they often don't make sense to people because you've distorted the very thing that people understand as areas. So that's the challenge. As soon as you change the area, people don't know where stuff is. So that's one of the ongoing challenges. The stuff around individual level data is basically a privacy problem. So I could show you individual movements of individual people around a city, but it's really quite hard to display that in a way that doesn't say something meaningful about who that person is. So you can basically work out who that person is. So when I show you my mobile phone data, I don't really care so much because it's at a scale where you can't really tell where I live, but you have a rough idea of where I've been around New Zealand in a year. So that's probably the main challenge with individual level data is you're really running into those privacy constraints, even though the data is underneath somewhere. So we normally aggregate up to kind of blur the data. Yeah.
Thank you. Just in the nature of time, I think we'll just take maybe 2 or 3 more questions. We did have one in the centre here first.
Thank you. You said you didn't want to use the COVID word, but it's actually really interesting. And particularly given that New Zealand was, I think, pretty well known for having had arguably a very good pandemic response. And so what work are you doing on that? And I'm thinking particularly with respect to sort of working out what do we do next time, what did work really well when another pandemic comes through, maybe doing some work with, are you looking at other countries who did it really badly? UK and America might be a good comparison. What are you doing with that?
Yeah. I think I would respond to that by basically saying I agree with the broad sweep of your point, which is New Zealand actually did do really quite well. And so the main challenge with COVID was whenever that arrived on our plate, it was completely unclear what it was going to be or what it was going to do. And so that was probably the main challenge, was that there wasn't a good kind of infrastructure to work out what to do, even though we'd kind of had a reasonable idea that there would be a pandemic. We didn't know when it would land. So I think in some respects, just having that capability in the background is probably the best you can do because you don't really know what's going to hit you. The thing, if I reflect on that personally, the thing that makes me quite proud to be a New Zealander and quite, really quite settled in this place is how amazing the New Zealand government apparatus and society kind of came together and dealt with that. I don't think you got that kind of instantaneous response and collaboration across boundaries in other places in quite the same way. I'm being quite careful what I say because some of the people who dealt with this are also in the room. But yeah, I think that's something that we can really be proud of as a nation in terms of the ability to work across the aisle, if you like, is actually quite unique. And I think that makes New Zealand a special place. So yeah, that's probably the most I can say without getting myself into trouble.
Thank you. I've got one question up here.
I'm Johanna and I'm a clinician. I was involved with the post-Gabriel response up in the East Cape, and when you sort of talked about movement of populations following earthquakes, part of my experience up there was roading networks that were down, and some things was restored very quickly, like sort of the main road around the Cape, but that still took a number of weeks, but months to years for a lot of those feeder type roads. Poor geographically, very spread out population. I had access to helicopters to get people out to Waikato or Gisborne, but it was really hard to get people out of valleys or bays. And but places like that, we can kind of learn a lot to plan for things like West Coast, Northland, areas of New Zealand that are similar for events like that. And I wondered if any of the work you've been doing, maybe post-quake, maybe over the COVID, is looking at any of those like lessons learned and modelling of how we can better plan responses. Because a lot of it happens quite intensely, but just into very specific areas. And if people can't get to those areas, the support is really difficult.
I might answer one part of that. We're just about to have a master's student funded by one of the hazards challenges looking at, and it's not really a health question, it's actually more of a transport question.
What's kind of a health
It is, yeah. And this project's actually going to be looking at what immediate transport needs do people have. So at the moment we kind of throw loads of money at, the hurricane. We throw tons of money without really knowing what people needed and how they moved around and what they needed to access in those days. So there is research ongoing, generally coming out of the hazard space, but they are working with us on that one. So we've got that connection. I don't know if you want to add anything more.
We did do some work actually in the Manawatu Gorge,
Yeah, we did.
if you
That's
remember,
true.
which kind of gets at the sort of lesson that you're telling us about there, which is if you close a major road, access to healthcare suddenly becomes really quite different.
That's true.
And so we did a project with a guy called Jaden McRae,
Yeah.
which kind of looked at that. So it's those almost natural experiments in some ways that you can learn something about what might happen.
One of the interesting things that happened there is actually a lot of people went to Palmerston North or were getting their care from Palmerston, but when they went a little bit further, it was just that actually that was a clinic that had capacity and did urgent care and saw it but they were doing care for people for 6 months plus. And so it's often people went to where there was farmland, which was probably related to labour movements 15, 20 years before.
And there's a link there with the work we've done on audiologists on the West Coast, that people don't always go to the local one because it might only be open a day a week. They go to another one which is further, but they do other jobs at the same time. So there's lots of behavioural stuff as well as the spatial stuff.
Yeah, and I mean, there's sort of simulation techniques and stuff like that we can use, but basically it comes down to we need some kind of data to basically start to try and model or predict what's happening. Cool.
Thank you. We've just got one more question in the front here, and then we'll wrap up our questions.
Excellent. Are you doing any work on chronic disease? We know things like autoimmune disease, cancer, heart disease, usually over a long period of time. What sort of longitudinal data do you have on people's movement? Are you doing anything in that chronic disease space?
Yeah, so there's two ways I can answer that question quickly. One is that a lot of the tracking data that we used was actually here and in Sweden looking at people with chronic obstructive pulmonary disease, so a real chronic condition of the lungs. And again, that was looking at how much air quality basically impacts on exacerbations, and then ultimately that leads to hospitalisation. So we've done some work on that historically. Phoebe actually and Susie in their PhDs have used the Christchurch Health and Development Study, which is a local longitudinal study like the Dunedin study, which basically has data on people over their lifetimes up to about age 40-something by now. So yes, we have done bits and pieces of work in that.
We also currently have a PhD student who's a vascular sonographer, looking at where people go for treatment and what impact that has on their outcomes, health outcomes. So we do some stuff, but historically it's been whatever the ministry priorities. And if you looked at the priorities, it kind of was in there, but wasn't top 10. So that's probably why we've not done as much.
Fantastic. I think that will wrap up our question session this evening. Just on behalf of the past and present GeoHealth Lab, I'd like to say thank you all in the audience for coming along this evening and helping celebrate the 20th anniversary of the GeoHealth Lab. And obviously, again, thank you to Simon, Malcolm, and of course Jamie, who joined us online for providing us with the lecture this evening. Would you like to talk to this?
Just to say, if you're interested in any of the kind of maps and stuff and you wonder how you might be able to do that, we actually put together an online course which was originally paid for by the Ministry of Health. So this is a complete sales pitch for UC, and the money is used to fund Maori and Pacific scholarships. So if you scan that QR code, you'll find that course, which is kind of an introduction. So therein ends my sales pitch. Happy to talk to anyone afterwards who's perhaps too shy to ask questions directly. That's fine. I'll be around for a while as well. So thank you very much for coming, and hopefully you've had an enjoyable evening.